4 weeks prior to foaling, I like to give a killed 5-way vaccine. So that's going to have influenza, rhinopneumonitis, the two types of sleeping sickness, so Eastern and Western. I tend not to give the Venezuelan, and then the tetanus vaccine. And so what that's going to do is give time for those antibodies to be concentrated in the maternal colostrum so that when the foal suckles his first milk, those are absorbed through the GI tract. I mentioned also that if these pregnant mares are in high risk environments, say like there's a strangles outbreak or a herpes outbreak or a diarrhea outbreak, any kind of neurologic outbreak, we need to isolate those mares for their safety. And again, protect the foal and protect, early, mid to late term abortions. These are the neonatal diseases that I want to talk about today. The ones that we commonly see are failure of passive transfer, sepsis, very, very common, and the corresponding sequelae that happen with sepsis. And so that is omphaloflebitis, which is going to be an infection of the umbilical stump, and septic arthritis can also be a horrible sequelae. We see colic, and colic can present similarly with a painful abdomen, but many, many disease processes can present the same way. We're going to talk about a little bit of ruptured bladder, gastric ulcer syndrome, enterocolitis, so the diarrhea foal that can present as colic, and very, very commonly meconium impaction. We see flexural and angular limb deformities. We also see commonly neonatal encephalopathy. The other name for that is neonatal maladjustment syndrome, and the older term is hypoxic ischemic encephalopathy. There is I should have mentioned enterocolitis after colic. Those are the diarrhea cases that will present. There are some heritable syndromes that we'll touch on briefly, and then some oddball things that we actually can see quite commonly: umbilical hernias, inguinal hernias, and or scrotal hernias. So things to keep in mind. Okay, so failure of passive transfer. That is when, when the foal suckles the colostrum, that is absorbed by receptor-mediated endocytosis. And so I can't emphasize this enough how important it is to get those colostral antibodies in sooner than later, because if the gut doesn't have any exposure to milk or colostrum, it's going to close sooner than later. Versus if we get at least something in, those receptors tend to stay open a little bit longer. And so within the first 18 to 24 hours of life, and the reason that I put those parameters down is because it's going to take about that much time to get absorbed. And so I like to do what's called a site test on the farm or stall side. And that is a qualitative test of immunoglobulin absorption, not a quantitative test. I don't want to send those samples to the lab and maybe get them back 4 or 5 days later. I want to get a general idea of, okay, did that foal have complete failure of transfer? That is, was it less than 400 milligrams per DL? Did it have partial failure or partial transfer at 400 to 800 milligrams per DL? Or did it have complete transfer of antibodies across the gut at greater than 800 milligrams per DL? And so we know that right away. It's a color pattern, and I'll show you a picture of that. This particular product here on the left is the commercial product that we use for septic foals and for failure of passive transfer. It's Immunoglow. I've used it for close to 30 years now and have had very good success with that. Commercially harvested and tested. And that leads us right into the first major topic of sepsis and omphalophlebotitis and or septic arthritis. So a lot of times these are the foals that have had failure of passive transfer. They have not had adequate absorption of antibodies across the gut wall. There can be other reasons. Maybe the placenta was infected. Did the mare have exposure to bacteria and viruses during pregnancy? And so this little girl, her name is Finn. She presented just within a few hours of age. The owner called very concerned. She was down and weak. She could not get up on her own. I want to say also that this is a draft filly. So she weighed probably 70 kilograms, greater than 150 pounds. And so she was impossible for one owner to get up on her own anyway, even with assistance. And so when I'm presented with a filly like this, you can see how dehydrated she is. Her eyes are sunken. She's very, very lethargic. Dry mucous membranes, poor skin turgor. You can see that she had what looks like bloody urine. And so we managed this girl out on the farm, and we had a runner to go back and forth to the hospital, which is about 45 minutes away from the farm. So I didn't want to have to go back and forth. I wanted to stay there and manage this filly. And so it was nice to be able to get our CBC and our chemistry and our urinalysis right away. Um, she had severe neutropenia. She had um, on her urine, I actually have her urine results right here. She had a urine protein of 4 plus, red turbid color. She had 10 to 15 white blood cells per high power field. She had greater than 100 red blood cells per high powered field. She had rare rods and she had rare coccycine. So we actually submitted that urine for culture, and we grew a pure culture of Acetinobacter species. So I just want to mention a few other laboratory abnormalities. Um, she was hypoproteinemic. That goes along with failure of passive transfer. Uh, and again, her creatinine was elevated. So she most likely had what's called pre-renal azotemia. Now, after fluid therapy and after I get her stabilized, if those kidney enzymes come down after fluid therapy, then I'm going to be much happier with her kidney function long term. And they did. Okay, so one important thing I want to mention about this girl, we expanded her fluid volume and her blood volume with IV fluid therapy before we gave her a plasma transfusion. And again, I had mentioned that she's a big foal. And so our standard light breed foal would probably get one of those bags of plasma. She actually got 2 bags. But again, hydrate these guys first. Otherwise, you're going to run into a hypercoagulable state if we just give, concentrated plasma. And so treatment was, we placed an IV catheter right away, gave her IV fluid therapy. We started her on broad spectrum antibiotics, IV. Again, whether I'm in the hospital situation or whether I'm out in the field, I like to start potassium penicillin and IV genicin or IV amikacin. And so broad spectrum meaning I'm trying to get both gram positive and gram negative blood bugs. Plasma transfusion came later. After this filly was hydrated and we supported her, she actually was able to get up on her own and nurse. And so thankfully, I did not have to place a nasogastric tube for feeding or give her parenteral IV nutrition. So Finn recovered. She stayed on antibiotics, a week, 10 days, 2 weeks. It kind of depends on the progression of the sepsis and how they respond to treatment, or whether or not we thought that she had to come into the hospital situation. So she recovered. To go along, to go along with sepsis, some of these foals may present with pneumonia and multi-organ dysfunction. And so they may present non-specifically. That is, they have a fever, lethargy, they have increased respiratory effort. You can see that uh, actually some of the diagnostic things besides your complete physical exam and auscultation, listen to the heart and the lungs really well. Are there wheezes? Are there crackles? Um, um, are there end expiratory noises? So the diagnosis is going to be based on physical exam and your lab work, CBC, a chemistry, probably also a serum amyloid A, SAA, and um, an ultrasound and a radiograph. You can see that the top left ultrasound image, there is consolidation. You may see thickening of the pleural lining. You may see fibrin deposition. You may see free fluid within the pleural space. And again, consolidation. What we want to do, a lot of times we need to culture these pneumonia foals because the treatment can vary uh, widely based on what organism is causing the pneumonia. Some of the more common types are Streptococcus, Actinobacillus, and Klebsiella. Some of the viruses that we see are equine herpes virus 1, equine herpes virus 4, and equine influenza virus. One thing that's not listed on here is an organism called Rhodococcus equi. We do see Rhodococcus here in Oregon. However, it's very, very common in the desert Southwest in hot, dry, dusty, arid environments. Um, this radiograph on the bottom left potentially could be a Rhodococcus pneumonia because you can kind of see the evidence of little microabscesses. That is what that organism causes. And it is treated very differently than some of our other organisms with your erythromycin, rifampin, um, versus some of the other potassium penicillin, gentamicin, and amikacin, some of the aminoglycosides. And so antibiotics is going to be a huge part of the treatment plan, plus or minus oxygen and supportive care. Some of them will need oxygen, especially some of those Rhodococcus foals. They present with high fevers, 104, 105, 106, tachypnea, and just all out respiratory effort. Okay, there's pneumonia. And on to, whoops, this is going way too fast. Okay, and colic. So I think I mentioned briefly that colicky foals kind of have a classic look to them. They roll up on their back and they curl their front legs onto their chest, and sometimes their back legs can look the same. They can be very, very painful for different reasons. Um, so you're going to have this foal with obvious outward signs of colic. But different conditions can present. So the picture on the top left is actually the little black filly that was down. That is her meconium impaction. So that was one other thing to add to her problem list. She she was so dry and so sick that I think we had to wind up giving her two enemas before she passed that meconium impaction. So I put that on the top of the list because it is so common. We see it very, very readily. Many owners actually carry little phosphate enemas in their first aid kit during foaling season. Um, we had mentioned ruptured bladders. So those foals are going to present usually within the first 1 to 3 days of life. And colts, it's more common than fillies. And so what happens is that colt he'll have a full bladder as he exits the birth canal. And the mare has such explosive pressure um, during the birthing process that she actually ruptures that bladder. And so um, the foals, their abdomen continues to get distended and quite colicky and quite sick. Gastric ulcers, again, gastric ulcers should be on the list. Is there a primary disease process going on, or is it primarily gastric ulcers? One other thing that they may be doing, which is a very common sign for foals, is called bruxism, and Bruxism, and that is grinding their teeth. Very common finding in painful colicky foals. And again, it may be primary, or many times there is another disease process going on, like sepsis or ruptured bladder. The enterocolitis cases, they will have sometimes pipe stream foul smelling diarrhea. The common organisms that we see are Clostridium difficile, Clostridium perfringens, Salmonella, E. coli. Some of the viruses we see are rotavirus and coronavirus. The parasites that should be on the list here in our area are strongyloides. And so that is the parasite that gets transferred from the milk. And then as the foal suckles, it will get infected with that. So similar diagnostics. We want to do a CBC and a chemistry, serum amyloid A, a fecal exam. So what we're doing is we're checking for parasite eggs, and also we want to culture, and we want to do some toxin analysis, culture for Salmonella, E. coli, and then the toxin analysis on the Clostridium organisms. Abdominal ultrasound is going to be very, very important. I couldn't find, I know I had a ruptured bladder full and I couldn't find that ultrasound image, but it's going to be very classic because your small intestine, your large intestine, your kidneys, it's going to be bathed in urine and they're literally just going to be floating there. And so we also want to add an abdominocentesis, because what you're going to want to do is check to confirm whether that is urine. You want to check the abdominal fluid creatinine versus the serum creatinine. And also you can just literally, you can smell it. It's going to smell like urine. Um, Also, we want to rule out peritonitis. Again, is there transformation of bacteria across the gut wall into the peritoneum? And so you may want to culture that abdominal fluid. The treatment is going to be directed at the specific diagnosis, and we've touched on that a little bit. This little girl, her name is Jimmy, and I wish I had time to go into her history, but her gray mother is back there in the background, and this foal was actually high risk for sepsis. Her mother had to have a temporary tracheostomy, and then I placed what's called a permanent tracheostomy in her cranial cervical area. That happened in October, and this foal was born in March. And so high risk for sepsis. And she is just an adorable little girl. Her name's Jimmy. Okay, back to enterocolitis. So really common finding, hopefully benign finding, is full heat diarrhea. It really doesn't have anything to do with the mare coming back into heat. Her true heat usually comes back in at about 30 days prior to foaling. But this is that first week of life when they're nibbling on their mom's food, they're nibbling on things in their environment, and their gut flora is getting developed. And so they're going through a huge transition phase. And sometimes, they'll present with diarrhea. Many of these little guys will be alert, bright, eating and drinking. And so it's a matter of monitoring. Are they sick, or is this self-limiting, and they correct the diarrhea on their own? Um, Sometimes I will add a gastric protectant like Gastrogard or omeprazole, sometimes Biosponge. I want to mention that Biosponge is made by a company called Platinum Performance, and it is an intestinal adsorbent, like say like charcoal. Um, you don't ever want to give too much of that product because you can actually go the other way and make them constipated. So just a little practical point there. Again, on these guys, we're going to want to take feces. We want to know, is Clostridium a player? Are the perfringes and the difficile a player? A fecal exam checking for parasites, and a culture and toxin analysis. Um, Again, during your initial physical exam, you're going to evaluate the hydration status. What are their membranes like? Do they have sunken eyes? Do they have poor skin turgor? Um, Sometimes we need to place an IV catheter and start IV fluids. Gastric support, that can be anywhere from omeprazole to sucralfate. Um, and then the probiotics and biosponge. Uh, if nursing care is important, they're going to have a wet behind, and um, want to keep them clean. We want to keep their rear end and their perineum clean and dry. And we want to put some type of an emollient back there, whether that is, we use Desitin, we can use Vaseline or Aquaphor, Xerasil. There's all kinds of products that help protect that skin back there because you don't want that skin to get infected as well. So lots of nursing care. I add metronidazole here because that is an antibiotic that it's called Flagyl, metronidazole, but we use that for the clostridial organisms. So that gets your gram-negative anaerobes. And again, some of these guys may present as colic. Okay, fun stuff here. Some limb deformities. Let's first talk about contracted tendons. So the little guy on the left, he actually comes up in a later slide. His name is Tito. He's the one that presented during the first few hours of life. He also had contracted tendons. And then so you can see on the bottom right photograph, we tried splinting and bandaging for his contracted tendons. He got both of those off within less than the first hour of putting them on. So he was like a little Houdini getting those off. Um, the other opposite end of that spectrum is laxity. And I would much rather deal with a lax foal who is down in their pasterns and their fetlocks than a contracted foal. They're managed completely opposite. Tito should be stall rested for many reasons. Um, if we let him out to exercise with his mother, his muscles, his tendons, his ligaments are actually going to get more fatigued, and he will contract more with exercise. Versus the opposite scale is a laxity foal. Those guys need exercise to strengthen their tendons and ligaments. Okay. Um, there's companies out there nowadays that actually manufacture fantastic splints that can be strapped on. but still to this day, I use cut down PVC pipe and cotton and vet wrap and bandaging, and we can still do a really good job. It's time consuming, it's labor intensive, but it works pretty well. Let's see. Let's talk about the filly on the top right. I also met this filly. Her name's Charlie. I met her on the first day of life. She had severe bilateral carpal valgus. And so usually we see carpal or fetlock, varus or valgus. Now remember, varus is going to be a medial deviation and valgus is going to be a lateral deviation. The way to remember that, guys, valgus, it has an L in it. And so that's lateral. They're going to toe out laterally. Her radiograph is there on the top left. The reason that I like to radiograph these guys, for one, I want to evaluate, is there any evidence of cuboidal bone hypoplasia? This particular filly was um, she was a rescue filly, and so we had no history with her mare care and the mare's nutrition. And so there was a chance that she was premature. Just subjectively, I feel like this filly has a little mild cuboidal bone hypoplasia. You can see that her growth plates are wide open, the angulation is severe. Um, and so it's a good idea to get those baseline radiographs. Now, going back, we talked about splinting and bandaging, and also corrective shoeing may be part of that management plan. So the one thing I also add in for severe cases is oxytetracycline. I'm not sure if you're familiar with that. It's an antibiotic, of course. The dose that I have listed there is 44 milligrams per kilogram. That is way different than the antibiotic dose. I also want to preface that before you treat these contracted tendons with oxytetracycline, be sure and do a CBC and a chemistry on these guys. I want to know, do they have normal renal function? Are they azotemic? If that's the case, I want to give them some fluid therapy prior to treatment with oxytetracycline. How I mix these up is I figure out their dose. And again, the last foal that I did this season, he was actually a miniature foal. And so I was able to hold him in my arms and put him right on the scale. Um, and so we figured out his dose. And then I put that in a 1 liter bag of saline and I give the medication over about an hour. And that foal only needed 1 dose and he did really well. I don't have a picture of him. He was a miniature foal. Okay, back to Tito. So Tito, our famous little guy in all of these slides. Um, he is the neonatal encephalopathy foal, neonatal maladjustment syndrome, hypoxic ischemic encephalopathy. Um, right there on the top of your screen is the modified APGAR. So back up just a little bit. He's the one that presented with severe dehydration. He did not know his mother very well. He didn't know us very well. He was kind of wandering around, kind of running into the walls, just a really severe presentation for a very, very sick foal, severely dehydrated. When I tinted this guy's skin, it literally stayed tinted for probably 10 seconds. And so just we're presented with this sick down foal. Um, so anyway, I add on here, there's a modified APGAR score, and that comes from human medicine. 0 to 10 is the scale. 9 to 10 is ideal. 6 to 8 is a telltale sign for moderate asphyxia, and the higher the score, the better. So the layman's term for this is a wanderer or a barker. Those are the classic names. The risk factors include dystocia, so that is the term for difficult birth, a C-section, and all the risk factors that go along with C-section, hypotension, cardiovascular collapse, lack of oxygen, you name it. Sometimes induction of labor. whether it's with oxytocin or steroids or a combination of the above. Tito actually had the bottom um, item there on the list. He actually had an overly rapid delivery. And so the reason we know that is because the owners went back and watched his birth on the camera in the foaling stall. And his entire birthing process was just, it happened in just minutes. And so, let's see here. Okay, so continuing on with Tito, that I think his mother had buried him in hay. It was just a cute little shot there. He was actually doing pretty well. We treated him with supportive care. So what we did, since we were just within um, probably within 1 to 3 hours getting to the farm after the owners had called and after he was born. So we wound up milking the mare out. We collected colostrum and antibodies from the mare. We passed a stomach tube on him and gave him enteral nutrition, placed an IV catheter. We did start him on antibiotics. We did start him on stomach protection. Um, Probably one of the most important things that I did was get him completely hydrated. Because what I wanted to know was he obtunded and was he lethargic because he was so dehydrated? Well, after getting him hydrated and urinating properly, he still had severe obdentation and lethargy. He just wasn't following his mare correctly. He wasn't following us correctly. And so then my working diagnosis at that time was neonatal encephalopathy. And so I mentioned also that Tito was born rapidly. So what happens is there is not enough time for the normal phases of birth to happen, and there's going to be altered concentrations of neurosteroids. That's what we think happened with Tito. So I'm going to back up just a little bit here. I'm not sure if you folks are familiar with the Madigan squeeze. Dr. John Madigan was my mentor when I did my internal medicine residency at Davis eons ago. And so this rope technique. You probably saw it when we were talking before. This is called the Madigan squeeze. And what he did is he designed this based on what we think happens during the birthing process and as the foal goes through the birth canal. So you take this rope and you put it through the front legs. You take a bowline knot, and then you half hitch loops around the chest. And then the end of the rope is going to come back toward the tail. And at that time, when we put this rope on, he was standing. And then you put gentle pressure and he's going to collapse and he's going to lay down. And you have your assistant cover the eyes. And you want him to lay down quietly for about 20 minutes. And real quiet environment. So lo and behold, we took the we took his blindfold off and we took his rope off. He got up and nursed right away. It's like the light bulb turned on. That's the running joke. Oh, their light bulb finally turns on. So that is the Madigan squeeze. In addition, I had added mannitol to his therapy. The dose for mannitol is 0.5 grams per kilogram to 1 gram per kilogram, 1 to 4 times a day. We can add caffeine and we did both mannitol and the Madigan squeeze on this guy. I didn't add caffeine because he had responded. So the report is that squeezed foals are 17 and a half times, whoops, 17 and a half times more likely to recover within 24 hours versus medication alone. So that's Tito. Ironically enough, funny story, my daughter adopted Tito when he was a year old. So he is actually part of our herd now, and we just love Tito. Okay, quickly, heritable diseases. I don't commonly see these. I just wanted to touch base a little bit. Lethal white overo syndrome. is a homozygous recessive. They are going to born albino white. There is a DNA test available. They present as colic because there is underdevelopment of the intestine and intestinal gangliosis. Very sad condition. Most owners nowadays are very informative. They don't breed overo to overo. Um, this next thing on the list is called a Max White foal syndrome. The reason I know about this is because I heard a story about an owner. She was very, very conscientious about her breeding, that she swore up and down that she did not have an overo to an overo Merida stallion, but the foal came out looking like lethal white, and but it was healthy. And so this syndrome is actually called Max White foals. I mentioned the next one. It's a fragile foal syndrome. I've never seen one. Um, there's weakness and fragility of the connective tissue leading to skin and joint problems. Again, it's autosomal recessive. There's thin, fragile skin, and they're present at birth and euthanized due to the severity of the condition. And there is a mutation of the PLOD1 gene, and there is a DNA test available, most commonly reported in warm bloods. HERDA, okay, it's not necessarily a neonatal disease, but I lumped it in there because um, we do see it. It's hereditary equine regional dermal asthenia. Now, there is weakness of skin, making it prone to tearing and ulceration, an autosomal recessive disorder, and there is a DNA test available. Okay, so moving on, totally different topic here. Um, so this guy, his name is Dante. He presented at a little bit older age, so he was a weanling, and he presented with an umbilical hernia. Now, the owner and I had talked about getting his umbilical hernia fixed, surgically fixed. We were just giving him some time to see if he was going to close on his own. Well, lo and behold, Dante decided that he was going to rush things along. So on a Friday night, he decided to severely colic, and I get out there. It was one of those hot Friday nights. He was drenched in sweat. He was down, rolling, colicky. Dante actually got small intestine trapped in his um, umbilical hernial sac. And when I got there, his hernia sac was the size of a large lemon and just hard as a rock. And so one of the first things that I did was actually reduce that small intestine back into the abdomen, and we put a belly band on him to get him transported to the hospital. So I was faced with two decisions. Do I jump in and do emergency colic surgery on this foal and repair the hernia, or do I stabilize him and get his cardiovascular status and his hydration status and his pain under control a little better? I actually chose the latter. I'm going to explain why I did that. So, when the small intestine is entrapped like that in that hernia, it can start to become necrotic and endotoxemia released in the bloodstream. That can be a crisis. I chose to stabilize him to prevent an endotoxic shower during surgery. And so we supported him through the weekend. We did a mini colic surgery, I guess, and an umbilical hernia repair on Monday. And so you can see that I have opened the hernia sac. I have removed it. And then I like to use um, I'm using a little spoon here so that I know that my needle and my suture is not going to get entrapped in that intestine. So I want to know that my abdominal wall is going to be opposed and that there's no intestine trapped in there. So we did a very brief, um, we ran the intestine briefly. There was no sign of necrosis or endotoxemia or any type of infection. So thankfully, I made the right decision on him. We waited, supported him, stabilized him, and did surgery on Monday. You can see the different causes there. Okay, and moving on. Let's see how we're doing. What, wrong way. Sorry. Moving on. Okay. So this is a patent urachus foal. The urachus is that structure that's going to hopefully normally close from the bladder to the umbilical stump. But sometimes they will present with both urine coming from the umbilical stump and from the urethra. Many times they present just with two outflows of urine, not necessarily sick. Sometimes I try to manage them medically with silver nitrate sticks to cauterize the stump. Um, Depending on the presentation, I may or may not put them on antibiotics. Again, they're probably going to be predisposed to urinary tract infections, so antibiotics would be a good choice. If you can't get them resolved medically, then surgery is always an option. Uh, it's much like doing an umbilical hernia repair where you're going to actually remove that stump and put the abdominal wall back together. And again, I'm a medicine person, not a surgery person, but I like to do surgery, and we get right in and do some things around here. So boy, oh boy, the take-home message. This is little Jimmy and her mom. There's such a backstory involved. I wish I had time to go through her backstory. She was born on my dad's birthday. And the day that I did the tracheostomy on the mare was the night that my dad died. And that filly was born the next spring on my dad's birthday anyway. It just, huh, lots of backstories, guys, lots and lots of backstories, and I'm happy to share with you. So the bottom line take-home message is be prepared. Be prepared for anything. Normal, abnormal, emergencies. Have very, very good relationships with your clients, good communication, good rapport. Um, Talk with them about everything during the pregnancy and leading up to birth. And like I said, be ready for any and all emergencies. So, all right, I am happy to answer a few questions. I know we're running short on time, and I hope you have enjoyed.
Well, if anybody doesn't have any questions, I would like to ask something about the contractibility of the
Yep,
tendons
yes,
that you mentioned that you used oxytetracycline.
yep,
I was looking about how it works,
yes.
and I don't know if you could tell us a little bit about it.
I can try to expand on that a little bit. There's been postulated theories that um, it helps bind calcium. And so if you bind calcium, what you're trying to do is relax that musculotendinous unit. So that's the old theory of why it works. We still use it to this day. I just want to I really want to emphasize to make sure if you use oxytetracycline, make sure that they have normal kidney parameters. Yeah.
And about antibiotic resistance, have you seen any case after you used it for treatment?
So using the oxytet in those contracted tendons, do I see resistance?
Mhm.
Not necessarily, but you touched on something that I wanted to touch on. And early on in my career, we used third generation cephalosporins very routinely as the broad spectrum antibiotic. We have way gone away from that because of resistance and because of detrimental and deleterious side effects with antibiotic induced colitis and diarrhea. So we have switched over back to potassium penicillin and the aminoglycoside antibiotic as the broad spectrum. But very, very good point about resistance as One Health and human medicine and equine medicine and even dogs and cats. We need to be very, very judicious about our antibiotic usage.
And about the penicillin potassium, do you
Yes.
use it? You use it to gram positive, you said,
Yes,
and something else.
that's going to be the one that I use to get the gram positives. So potassium penicillin, it comes in a crystalline bottle. And so we are going to reconstitute that with sterile water, and then you keep that in the refrigerator. That's going to be the one that's going to get your streps and your staphs. The aminoglycoside antibiotic is going to get the more gram-negative organisms. I will also mention about potassium penicillin because you brought it up. That needs to be given slowly because we don't want to cause an arrhythmia with the potassium. It's happened to me before when, when I was in a hurry and I'm like, oh, I just pushed it. Oh my gosh. It's a little scary when you push that potassium quickly.
Okay. No sé si alguien más tiene alguna pregunta para la doctora. Podemos dar unos minutos.
So Deanna, does everyone have access to my email or WhatsApp or messaging?
I don't think they do, but I can send or maybe if you have access to the chat, you could send your email.
Yeah, so
También
uh,
voy a mandar por el chat un enlace, es un forms para que por fin nos pongan su correo para la asistencia de la charla.
okay, so how do I get da, 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 da. Do I stop sharing my screen to get back to the Zoom?
No, yo puedo leer la pregunta, perdón. Alguien, somebody has a question.
Oh, okay.
Ujú. También Ale, tal vez que está levantando la mano en lo que José Andrés nos la manda.
Hi, I really liked your presentation. I have one question.
Sure.
Are there any different specific signs of colic in foals versus adult horses?
Yeah, very good question. So I kind of joke that the colicky foal is they're babies, and really they are babies. So they present as a baby and they act like babies. They don't handle pain as well as an adult horse that's going to present as colic. Some of those old horses can be so stoic and they don't let on um, as much as a neonate would. It's going to be pretty obvious in a neonate. They're going to be down, rolling, sometimes thrashing. Um, I go back to that Jimmy and her mama, her gray mare. There was even one time after birth, like several months later, that the mare actually got cast in a stall. The baby got caught up in the mare's casting. They both presented for colic. And so that little filly is a survivor. Oh my gosh, she's a survivor. Many of these colts are survivors. They survived multiple conditions. So just some little, So yes, very good question. They can present fairly violently with pain. Thanks for the question. Deanna, so sh- I'm trying to get back to the chat so I can put my email down there.
Mitzi already sent it. Sorry, I thought it was you. Mitzi sent it. Sorry.
So you got the Leah Gray DVM? Okay, very good. Very good.
Okay. About the other question, it says, what do you think about use fecal transplant in foals with enterocolitis or in cases with
Okay.
prolonged antibiotic therapy? What do you use?
Very good question. And so I don't routinely transphonate them by nasogastric tube. What I actually like to do is I take feces from a normal gelding and I throw it in the stall with the baby. And so those microbes are going to get in that gut one way or another. And so that's kind of my practical way to transphonate these babies. Very good. What we want to do is promote the health of the microbiome. We want to get their good gut flora going. And then in the meantime, we're just supporting them in the meantime with fluids and stomach protectants and tackling the specific organism. There's also been question and, a little bit of controversy in the past. Let's say we have a diarrhea adult or a colicky adult, and we take a stomach tube and we transphonate. We mix up a fecal slurry and we transphonate them by stomach tube. Okay, so how many of those organisms are going to survive past the acid in the stomach? Good question. Very, very good question. I don't know. Because we want to get it back to the hind gut where it's going to do its job.
Ok, no sé si alguien más tiene una pregunta, pueden escribirlo también en el chat.
Thank you all.
Okay. Well, thank you so much, Dr. Leah. As for me, I learned a lot, and I'm really, really thankful for the fact that you took your time and to teach us because it was a really good lecture.
And it's a very expansive topic, and you guys, we just touched the little bit of icing on the cake with this topic. So we could go on forever. In fact, we could go on forever just with dummy foal syndrome and neonatal encephalopathy. So, all right. Take care, everybody.
Muchas gracias a todos los asistentes. Cualquier cosa, por favor, llenar el forms que está en el chat y les agradecemos mucho su asistencia. Muchas gracias. Thank you so much, Dr. Leah.
Adios.
Bye.
Adios.
Thank you, Dr. Leah, and happy birthday.
Thank you, Mitzi.
You're welcome.
Thank you, Mitzi.
Bye. See you soon.
See you soon.